Buerger's disease, otherwise known as Thromboangitis obliterans. It is characterized by recurring inflammation of intermediate and small arteries and veins of the lower and upper extremities. Mainly, the lower extremities will be affected more than the upper extremities. It results in thrombus formation and occlusion of the vessel. The main etiology and pathophysiology of Buerger's disease. The main etiology is unknown. It is believed to be an autoimmune vasculitis that causes Buerger's disease. The main precipitating factors are the gender, that is male gender are the most precipitating factor. Then age between 20 to 60 years of age. Then history of hypertension, hyperlipidemia may cause this Buerger's disease. Then genetic is one of the reason. Then races, that is Southeast Asians, are common with this condition. Then predisposing factors, mainly lifestyles, that is cigarette smoking, tobacco chewing, are more prone to get this disease. Then sedentary lifestyles. Then environmental factors like exposure to cold and stressful environment, both are predisposed to this condition. Actually, the cigarette smoking is one of the main reason for the Buerger's disease. So, we knew that the cigarettes contain nicotine, carbon dioxide and carbon monoxide. So, the nicotine that leads to vasoconstriction of vessels. Then carbon monoxide that cause destruction of the lining of blood vessels, and carbon dioxide that cause decreased oxygen transport to tissues. So, all these factors that leads to trigger autoimmune response. So, when the autoimmune response is activated, that leads to vasculitis, and ultimately there will be ulcer formation and gangrene. So, that is the pathophysiology. The main symptoms of Buerger's disease include weight loss, abdomen pain, pale or red or blue tinted hands or feet, cold hands or feet, sores or ulcers on the hands or feet, severe pain in hands or feet, pain in lower arms and legs. Pain is the outstanding symptom of Buerger's disease. The patient complains of food cramps, especially of the arch after exercise. The pain may be relieved by rest, but cold sensitivity of the Raynaud's type is found one half of the patients and frequently confined to the hands. Digital rest pain is constant for this patient. The physical signs include intense rubor or reddish blue discoloration of the foot and absence of pedal pulse, but with normal femoral or popliteal pulse. But when we are assessing the pedal pulse, it will be absent. Radial and ulnar pulse also diminished here. Then paresthesia may be seen. Then color changes may lastly progress to ulceration, and ulceration then progress to gangrene. So this is the development of Buerger's disease. The diagnosis of Buerger's disease done by assessment of history, then physical examination, segmental limb blood pressure that taken to demonstrate the distal location of the lesions or occlusions. Then duplex ultrasonography are used to document patency of the proximal vessels and to visualize the extent of distal disease. Then contrast angiography can be done to demonstrate the diseased portion of the anatomy. Then diagnostic criteria include smoking or tobacco use, onset at less than 45 to 50 years of age, infrapopliteal, segmental, arterial occlusions with sparing of the proximal vasculature, frequent arterial involvement in the distal upper extremities as evidenced by Raynaud's phenomenon or digital ulceration, superficial phlebitis, then exclusion of diabetes, atherosclerosis, true arthritis, etc. The main management of the Buerger's disease, it includes general recommendations, smoking cessation, exercise, then avoid trauma to the extremities, then treat infection with antibiotics. For example, vasculitis have to be treated with antibiotics. Then local wound care. Here we have to lubricate the skin with lanolin based cream and lamb's wool between toes in case of ulcers or gangrene. Then medical treatment, mainly in order to control pain, we can administer narcotics because the pain is very excruciating pain. That's why narcotics have to be administered. Then narcotics. Then calcium channel blockers, especially amlodipine and nifedipine, can be given. Aspirin and clopidogrel, that is antiplatelets, also can be given. Then NSAIDs in order to control the inflammatory response. Then iloprost. Then spinal cord stimulators also can be given. Then endoscopic sympathectomy. Then vasodilators in order to improve the circulation. Then surgical management, that includes infrainguinal bypass with vein or surgical sympathectomy. Surgical sympathectomy that will improve the blood circulation and vasodilation.